Hello, my name is J E Bower, and I'm going to be discussing with you today the disorders of the integumentary function, and specific epidermolysis bullosa. Today I'm going to present to you Stephen. Stephen is a 6-year-old boy who presents to the pediatric emergency room crying, and he also has blood on his clothing and coming from his mouth. He does have an existing diagnosis of epidermolysis bullosa. Therefore, he does have gauze bandages over all of his extremities, and this is his usual wound care routine. Stephen has fallen off of his porch per his mother. He does have fresh bloody drainage on the gauze on his right forearm and right knee. He appears to also have knocked out one of his teeth. An overall assessment of Stephen after getting adequate pain control with intranasal fentanyl and bandage removal is that Stephen is 20 kilograms, his heart rate is 160, his respiratory rate is 28, his oxygen saturation is 96%. We are unable to obtain a blood pressure at this point because of his pain and the fear of damaging his skin with the blood pressure cuff. After removing the bandages, it's seen that he does have fresh wounds to his right knee and his right forearm. He also has numerous other lesions and blisters in various stages of healing over the rest of his body, and this is consistent with epidermolysis bullosa. We also see some controlled but oozing bleeding from that upper gum where the tooth was knocked out. The gum also appears to be macerated. The plan for Stephen is to gently care for his wounds and then rebandage them with non-adhering foam bandages such as Mepilex, cover it with Telfa, and then wrap it with gauze and cover it with a burn net in total. He will be discharged home with plans for a follow-up visit to the wound care clinic and with his dermatologist and dentist. To summarize epidermolysis bullosa, it is a rare, incurable group of genetic integument disorders that are characterized by extremely fragile skin that is prone to blistering and that leads to painful wounds, scarring, and decrease in functional capacity. There are 3 major types. There's epidermolysis bullosa simplex, junctional EB, and dystrophic EB. There are also many subtypes within each of these categories. For Stephen, it has been determined that he has a recessive dystrophic epidermolysis bullosa, also subcategorized as generalized intermediate. For the prevalence and incidence of EB, it will occur in 1 of every 50,000 live births in the U.S. There are an estimated 500,000 people worldwide that are affected by EB. And it does affect all races and ethnicities and has no gender predominance. The significance, the causes, and risk factors of EB are as follows. Epidermolysis bullosa is an inherited disease of the skin and mucosa, and it's caused by gene mutations that lead to defects in the proteins that usually create the epidermis. Since it is hereditary, EB can be either autosomal dominant or autosomal recessive. Milder forms of EB, such as EB simplex, are usually dominant. More severe forms, like junctional and dystrophic EBs, are recessive. And as we talked about, Stephen's form of EB is the recessive variety, so it is more severe, though his particular type is intermediate. The optimal care for these patients with EB is in a disease-specific or EB-specific multidisciplinary clinic. These clinics have easy access to dermatologists, wound care certified nurse specialists, pain management specialists, dentists, ancillary therapists like physical therapy, occupational therapy, speech therapy, psychologists, and counselors. Stephen's recent falls and injuries would be very well managed in such a clinic as this. And Stephen's parents are getting overwhelmed with how many visits that they have to make to specialists and so many different sites. It has been noted by Ahmad and Bruckner in a 2014 survey that there is a scarcity of EB-specific evidence-based guidelines. This would be a great opportunity for nurses in research to use these clinics and other EB patients to come up with guidelines that are evidence-based for best practice for these patients. The pathophysiology of EB is characterized by the location of the main gene mutation that causes the defect. But first, let's cover let's do a little review of the skin. And of course, we just read about the skin or the integumentary system in our chapter. There are three layers: the dermis, the epidermis, and then subcutaneous fat. Between the dermis and the epidermis is a basement membrane. This is where blisters are formed. And this is where most of the gene mutations for epidermolysis bullosa are found. For epidermis bullosa simplex, the defect is specifically in the K5 and K14 genes. This affects keratin production, and the layers of the epidermis just break apart. For junctional EB, you'll see that the gene defect is the LAMB3, and this occurs where the dermis and the epidermis meet. And it codes for the lamina lucida, which holds the dermis and the epidermis together. And then in dystrophic EB, the mutation in the type 7 collagen gene is what causes the defect. And these are in the anchoring fibrils. This actually causes a separation of the subbasal lamina. Clinical manifestations are determined by the actual topographic location of the particular gene mutation. Each type of EB presents a little differently. EB simplex, since it is a defect primarily of the keratin, you'll see nail dystrophy, hair loss or alopecia, and mucosal lesions. EB simplex is the most mild type of this disorder, and a lot of times the symptoms will decrease with age. You do not see the scarring that you typically see with the more severe forms. For junctional EB, you'll also see the blistering and the alopecia, as you'll see with all forms of EB, but you'll also see something called anonychia, which is no nail formation at all. Junctional EB can also affect the mucosa of the GI tract or the upper respiratory tract. You can also see severe malnutrition. Junctional EB is often fatal in infancy because of the severe complications from respiratory tract disease characteristics and failure to thrive from malnutrition. In dystrophic EB, the blisters do not heal well and become things called dystrophic lesions. These non-healing lesions are more susceptible to infection. You can see severe scarring that leads to disfigurement. You also see malnutrition, anemia, also a lot of emotional and psychological issues due to chronic pain and illness. And then to revisit Stephen, again, his type of epidermolysis bullosa is the recessive dystrophic type. His manifests with multiple blisters and lesions over his body, primarily his arms and legs, because this is where minor trauma usually occurs. At the wound care clinic for his follow-up, they see that there's no new blisters since his fall, but the wounds on his arm and knee have been slow to heal, especially the one on his knee, which is now draining a small amount of purulent exudate. He has started on PO Bactrim 3 times a day. Stephen also visited his dentist, who's concerned about the maceration on his upper gum where the tooth was knocked out. His mother reports that he's been eating less because of the pain in his mouth. So the dentist is also concerned about malnutrition and recommends that Stephen only get soft foods and then to also supplement with Boost or Pediacare. It's very important that Stephen return to a normal nutritive state, as this may help his wounds to heal better. To diagnose epidermolysis bullosa, the diagnosis can actually be suspected any time that there is a family history. The concrete diagnosis is most often with a skin biopsy studied under immunofluorescence microscopy. Genetic testing may also be used as a definitive diagnosis if epidermolysis bullosa is suspected. Just to return to Stephen, his mother is worried that her younger child may also be diagnosed with EB, and she's justified in her concern about this due to the hereditary nature of the disease, and genetic testing will paint a clearer picture. A brief overview of therapies or that the goal of treatment for EB is primarily symptomatic, not curative. You need to prevent new injuries, and pain management are the highest priorities. In 2015, Shikuma stated that the prevention of new blisters and ulcers and then wound care are the most important aspects of treatment. Preventive measures include protective clothing or bandages, laxatives to prevent rectal tearing, physical therapy to maximize mobility and decrease falls, and then using mobility-assisted devices like wheelchairs or walkers. And then pain management is also paramount to maintaining an adequate quality of life. And measures for pain management include, of course, medications over the counter or opioid, depending on the severity, and then behavioral or psychological therapies like cognitive behavioral therapy, visualization, distraction. Now, specific measures, or therapies, will be covered. Medical and nursing considerations for therapies, of course, include medications that are used for pain control, for itching, for excessive sweating, and of course for infection if there's any present. There's also specialty care within nursing. You have wound care, certified nurse specialists, and then case managers are very important due to the number of specialists and the need to manage and coordinate that care. And then, of course, psychologists are very important. And then if there may be surgical therapies or needs for surgery at times. Sometimes it's required to separate fused fingers and toes because of scar tissue, or even loosen scar tissue at the joints. If surgery is needed, extreme care needs to be taken with any intubation. The endotracheal tube and the laryngoscope need to be lubricated very, very well to make sure that there's minimal trauma to the airway. And then also care needs to be taken when securing the tube to minimize any further trauma to the mouth or the dentition. Other therapies include ancillary services like physical therapy, speech therapy, or nutritionists. And then there are some complementary or alternative medicines. As we mentioned earlier, the use of cognitive behavioral therapy, hypnosis, biofeedback, or relaxation training. However, herbal mixtures are not often recommended due to the possibility of increased bleeding with some herbs. And here is a table of the different medications that are commonly used for some patients with EB. This is in no way an exhaustive list of medications. It also does not include often used antibiotics, as the choice of medication for that would be specific to the type of infection. And the dosages that are listed in this chart are those that would correspond with the weight of Stephen, who is 20 kilograms. And as you can see, with the pain medications go from mild analgesias to severe pain management with opioids. You also use antihistamines for itching, and then you also use anticholinergics occasionally to help with excessive sweating. The three most serious complications, or some of the three most serious complications of epidermolysis bullosa, are the physical disabilities, malnutrition, and of course pain. With physical disabilities, the skin is almost always in a state of blistering or healing, and this leads to scar tissue that is forming over and over again. And then as Grossman says, when scar tissue contracts, especially over joints, it tends to limit movement and can cause deformities, which obviously leads to physical disabilities. Another serious complication is malnutrition. PO intake may be very poor in people with epidermolysis bullosa due to the disease affecting the oral mucosa, dentition, and the GI tract. EB patients also have an increased calorie and protein need because of the energy required to heal their wounds. In addition, protein deficiencies also cause pathophysiological complications at the cellular level, and this may further delay healing. And then, of course, another serious complication with this disease is pain. Persons with EB experience both acute and chronic pain. And then acute pain is most often brought on by the daily dressing changes and the bathing. And in addition to the physiological changes brought on with acute pain, like increased heart rate, you can also see increased anxiety. Persons with EB also suffer from chronic pain because of the effects on the skin, the GI tract, and the musculoskeletal system. Chronic pain can often be associated with sleep disturbances, loss of appetite, and depression. The prognosis for EB depends on the type and the subtype of the disease. Such as EB simplex and dominant dystrophic EB, you may only see mild blistering. And again, the symptoms may decrease with age. With junctional EB, you'll see severe presentation in the mucous membranes, especially the oral mucosa, the nasopharynx, and the GI tract. And again, they rarely survive beyond infancy. And then with the recessive dystrophic EB, which is what Stephen has, the disease often manifests in multiple systems beyond the integument, such as the GI, the GU, or the cardiovascular system. Patients also have a high likelihood of developing squamous cell carcinoma, and often, unfortunately, they do not survive past 30. Again, this is the subtype that Stephen has. It has manifested in him with the characteristic blistering of his skin and mucosa. He has increased scarring over his distal extremities. This requires him to attend physical therapy 2 times a week, and he also has exercises to do at home. But with quality and multidisciplinary care, Stephen should live into adulthood. Now to cover some evidence-based nursing interventions and goals. The first and one of the most important is wound care management, and there are several subcategories beneath wound care management. The first is to assess and inventory the wounds. The goal of this is to locate existing wounds and document the characteristics of each. An assessment tool to use could be one called Measure, or you could photograph the wounds, and that would be useful. This should be reassessed every 6 months. For wound cleaning, the goal is to prevent infection and encourage wound healing while causing minimal pain. The wound should be cleansed gently with normal saline or water. You may also soak each wound in a diluted solution of vinegar or bleach. And this is performed daily as long as there are open wounds. There are also entire body soaks in a salt or bleach solution that can also be useful to decrease the likelihood of colonization of bacteria. And altogether, the daily bathing and wound cleaning can take up to 4 hours. For blister management and wound debridement, the goal is to prevent blisters from tracking or growing beyond their original borders. A sterile needle is used to puncture blisters and drain them. Then the top is left intact, and this serves as a biological dressing. If there is prolonged healing and eschar is formed, debridement will be needed, and this further inhibits inflammation and infection. And speaking of infection, the goal for that obviously is to promote optimal wound healing. It is common for the wounds on EB patients to be colonized with usual skin organisms, and this doesn't become an issue unless they become what is called critically colonized. And this means that if it really affects the healing time of the wound, or if it affects the tissue deep beneath the wound itself. There's an assessment tool called NERDS that can be used to determine the level of infection if it's suspected. And then the therapies for infection control would be oral antibiotics for deep tissue infections, IV antibiotics for suspected systemic infection. It is recommended to only limit use of topical antibiotics due to increased resistance of organisms. And then the dressing choice is also under wound care and management. The goal of this is to provide an environment for optimal healing and comfort. The type of dressing depends on the location, size, and drainage from the wound. The appropriate dressing for Stephen's knee, for example, since it is draining and is over a joint, is a foam dressing covered by a modified absorbent pad kept in place with a contact layer that doesn't actually adhere to the skin, and then protected all by a burn net to keep it in place over the joint. To continue with further evidence-based nursing interventions and goals, we'll cover activities of daily living. The goal is to foster safety and independence during daily life with chronic disease. This largely depends on the developmental stage of the patient for what appropriate interventions should be taken, such as diapers without elastic lining for infants or knee pads and special shoes for children of school age. Other nursing interventions would be with pain management. The goal for this would be to assess pain accurately, treat it adequately, and reassess the need for further pain management. And there's two strategies for pain management. First is preventive, and that would occur with wound management and some of the ADL considerations. And then, of course, there's therapeutic. This would be medications and non-pharmacological techniques. And lastly, we have nutritional support. The goal of this is to minimize nutritional deficits to improve wound healing, immune status, and bowel function while optimizing growth. If there's just minimal calorie and protein supplementation needed, then proprietary multi-nutrient supplements like Boost or PediaCare are encouraged. Sometimes gastric tubes may be required for more severe malnutrition, but if this is the case, special padding and special care around the skin of the stoma needs to be considered. NGs and NJs are not recommended due to the potential damage to the esophageal and nasopharyngeal mucosa. To follow up with Stephen, and to end our case study, Stephen's injuries to his right arm and knee have been slow to heal, with the knee in particular being infected. He's also lost some weight because of the wound on his upper gum that causes eating to be painful. His decreased eating may also be contributing to his slow wound healing due to poor nutrition. Because of these factors, Stephen's parents are realizing how beneficial it would be to have a dedicated EB clinic close by with multiple disciplines available. They have decided to move to a city that offers one of these clinics. This clinic will also have counseling available to help Stephen learn to cope with his chronic illness and how others may perceive him because of it. There will also be support groups available for his parents. A key factor to the success of the EB clinic is the use of best practice guidelines for wound management, activities of daily living, pain management, nutrition, and social support.